session, I'm going to focus on lymphomas. This is probably going to be a massive talk. So it will be on basically lymphomas, which are cancers that originate from hemopoietic cells. And I think it's important, I'm going to try this pen out, and I think it's important to actually say these are blood cancers that originate from hemopoietic cells. And hemopoietic cells are obviously cells that differentiate into different blood cells, such as lymphocytes, leukocytes, myelocytes. So in lymphomas, these cancers, then the cancerous development or the malignancy then forms a distinct defined mass in a secondary lymphoid organ, or indeed in a primary lymphoid organ, but it's usually in a secondary lymphoid organ, such as a lymph node, perhaps the thymus, perhaps the spleen, and obviously, lymph node. I have said lymph node. And lymphomas in generally are divided into two classes or groups, really. Shall I say two types? And we have non-Hodgkin's lymphomas and Hodgkin's lymphomas. And really, Hodgkin's lymphomas are distinguishable or defined by the presence of a red Steinberg cell, which is really a bilobulated nucleus on the cell, and it's a large cell. And that bilobulated nucleus gives the appearance of owl's eyes. I don't know if I go to owl's eyes. And everything else that does not have the red Steinberg cell is then a non-Hodgkin's lymphoma. So these are the two types of lymphomas that we know of and that exists really. It can either be a Hodgkin's lymphoma due to the presence of a red Steinberg cell, or it can be a non-Hodgkin's if it does not have a red Steinberg cell. So in the World Health Organization then classifies all lymphomas based on classification. Can either be the pre-lymphocytic of B cell, or peripheral. Again, it's going to be B cell, or if it's 1, 2, 3 will be will be pre-lymphocytic, again of either T or NK type cell, or peripheral T or NK cells, or a Hodgkin. So really, these are obviously the non-Hodgkins, and then this is the Hodgkins. And then another thing to really be the pre-lymphocytic are really the closer to being a blast cell, because if we remember, I think I was going to do it there, then I did something else. But if we were to remember that, we start off with a multi potent stem cell that then enters into the it becomes a pre-lymphoblastic cell, and from these we'll then have dendritic cells, which are peripheral, and they're small. You know, all peripheral cells are small, and they are well differentiated cells that, you know, have a specific job to do. This pre-lymphoblastic then becomes a lymphoblast, and that lymphoblast can then either be part of the T or NK peripheral cell, as it differentiates further, or it can become part of the B cell and indeed a plasma cell. So really the definition of those cells, like if a cell is much closer to being a lymphoblast and it's large, blast, then it's normally called an aggressive, because it's still a highly proliferation cell, so it's like high proliferative. However, if a cancer occurs much closer, actually I should have probably did a site there. I should probably say lymphoblast and then say lymphocyte, which can then be and then say if a cancer develops from when a cell is much closer to being a peripheral cell, you know, along, say, perhaps this, say if this one develops somewhere near the blast, either there or there, then that will be a much more aggressive cancer. Whereas if a cancer develops somewhere nearer to the end, then it's more of a chronic cancer, which are indolent and less aggressive. And usually it's simple because these are mature cells which are small and much more differentiated, so they are not proliferating as fast or as quick as the immature cells that are still trying to grow and become much more mature. Anyway, that is a very quick definition of what lymphomas are. And lymphomas are all, so I've talked about the two different types of lymphomas, and they're all classified using the Ann Arbor classification. So they are all, their classification is based on the Ann Arbor system, staging system. And the most important thing to remember is that there is staging in lymphomas, there is staging and grading. Grading is completely different, is two different things. However, the staging is usually based on the Ann Arbor staging, which divides the body into two based on the diaphragm. And stage 1, for example, it will, the diaphragm is there, so it will say this is the one part of the body, and everything else is the rest part of the body, but it's all divided based on the location of the diaphragm. Sure, you should say location of diaphragm. So stage 1 is just having one affected organ or region, it doesn't matter, obviously there's just one affected organ, or shall we just say obviously it's a lymphoid organ or lymph node really. And then stage 2 is having at least two affected organs that are on the same side, of the diaphragm. Stage 3 is having affected organs on both sides of the diaphragm. Diaphragm. Again, it doesn't really matter where it is, it's just that it's on both sides. And then stage 4 is having lymphoid organ affected and an extra lymphoid organ, such as liver, spleen, abdomen, such as liver, spleen, etc., etc. So that is the staging. So if this was a human body, I don't know whether to borrow my model. So the diaphragm will be sitting there, and then one with stage 1 might have a lymph node there, say in the cervix, or perhaps have it in the axilla, or perhaps have it in the mediastinal, or have it in the supraclavicular there. It's still stage 1, it doesn't matter. And for it to be stage 2, again it will be perhaps, or perhaps stage 1 can also perhaps be inguinal, or peritoneal, suprarenal. As long as it's below the diaphragm, then it's still stage 1 and is one place. Stage 2, it can either perhaps be cervical and supraclavicular, or cervical and axilla. It's still stage 2. It's in one part. Similarly, it can perhaps be inguinal and gonadal. It's still stage 2 because it's still on the same side. Stage 3, it's if you have, say, supraclavicular and inguinal, because both sides of the diaphragm are affected. And stage 4 will be, say, supraclavicular, inguinal, and perhaps the bone, the tibia, or perhaps the liver, which will be there, or perhaps the GI itself, the GI tract. So it's that having that extra lymphoid organ being affected, or perhaps the brain. So then that is stage 4. Obviously, stage 1 and stage 2 we have a better prognosis. Stage 3 and 4 have a much worse prognosis. And because of this classification, the diagnosis of all lymphomas must include, to confirm, all lymphomas are confirmed with excisional biopsy, and chest x-ray and CT of the chest, the abdomen, and pelvis. So you do need all those 3 organs to be scanned with a CT in order to accurately stage the disease. Obviously, these are how to confirm the diagnosis, but obviously things like bloods will have to be done in order to see if there's anemia. Enzymes must as well be assessed in order to see if there is perhaps liver function, failure of the liver, renal failure, or indeed the lactase dehydrogenase, which is a very important marker of tumor burden. If it's increased at any time, when you do the bloods, then it shows that there is a higher tumor burden and a poor prognosis, and therefore it must always be performed LDH. And then in talking about lymphomas, I have discussed what they are, and they are obviously differentiated from leukemias because leukemias are found within the blood and they do not form a discrete mass, whereas lymphomas will form a distinct mass somewhere in the body. They might not necessarily affect the blood, but they might enter the blood in order to invade other organs, or to then go and form a mass in other organs. But I think diffuse large B-cell lymphomas has an intravascular subtype, so it's not entirely correct to say they do not enter the blood cells, but the difference is that wherever they are, they will form a mass, a solid mass that is defined and that can be seen, whereas leukemias are more fluid and they flow all over the body. And another thing, in terms of the presentation of all lymphomas, is you will always have lymphadenopathy, which is usually painless. And that lymphadenopathy, so this is the presentation of lymphomas in general. I'm still speaking generally, really. Will always have a lymphadenopathy which is painless, and the lymph nodes will feel rubbery. However, it's always painless. They might also have additional B symptoms, which include night sweats, fever, weight loss, and anorexia. However, not all of them will have B symptoms. For example, Beckett's lymphoma does not always have B symptoms. They will also have the general unwellness, I suppose, which comes with the cancer. However, the most important thing is the lymphadenopathy that is painless, which obviously is distinct from other lymphadenopathies that can be painful, particularly if it's an infection of some sort, and that rubbery, lymphadenopathy. So really, in terms of I think I probably should start with Hodgkin's because it's quite straightforward and it's quite easy and it's quite very brief to talk about, really. So Hodgkin's lymphoma, or did I really say oh my god, I cannot spell for the life of me. non-Hodgkin's lymphoma. I think that's how you spell it. For example, whenever I get to the board, I find that my spelling just goes. Anyway, Hodgkin's lymphoma is a blood cancer, as we have said. That defined. I'll say defined by the presence of the Reed-Steinberg cells. And Reed-Steinberg cells, as I've already said, are bilobulated nucleus cells. So they will have a lovely nucleus that's like that, and this will be like a bilobulated cell. So you'll have cells that look like this, you know, and it doesn't matter how the background is. The background might be other cells, but then that finding this cell with owl's eye tells us that this is a Hodgkin's lymphoma. So they are defined by the presence of a Reed-Steinberg cell, and there are two types of Hodgkin's lymphoma. We have the nodular lymphocytes predominant Hodgkin's lymphoma, or the classical Hodgkin's lymphoma. And the classical is subdivided into the nodular sclerosing Hodgkin's, or the mixed cellularity, or the lymphocyte rich, or lymphocyte depleted. And we differentiate between the nodular lymphocyte predominant and the classical by the presence of, all classical will be CD15 and CD30 and CD25 positive, whereas these ones are negative. So these ones are all positive for this, the classical. So if we find, particularly in fact it's these two anyway, CD15 and CD30, then so if you have CD15, CD30 and a Reed-Steinberg, it's classical Hodgkin's lymphoma. If you have negative for CD15, if you have a Reed-Steinberg but it's negative for CD15 and also negative for CD30, it's nodular lymphocyte predominant Hodgkin's. That's how that is the best way to differentiate between these two, and they are all both types of Hodgkin's lymphomas. And Hodgkin's lymphoma, as I've said, it presents with painless lymphadenopathy. However, these lymph nodes become painful following alcohol consumption. So they will have a sharp pain, on whatever lymph node is infected. Say if it's cervical, they will have that sharp pain on the cervical lymph nodes following the consumption of alcohol. Hodgkin's lymphoma is also known to have, I think really the most important thing why I mentioned this was because I wanted to mention this because I've already mentioned that they all present with that and B symptoms. It has a bimodal distribution, in the sense that it will affect people like young adults, it will affect young adults between the ages of perhaps 15 to 30. Some books say 20 to 30, and then there is nothing in between, and then until older than 55 years old, and then older adults. So these young adults and the older adults are affected. So there is a bimodal distribution. It is linked to EBV virus, Hep 8, like Hep C, and then hepatitis 8. Did I say hepatitis C and hepatitis C and herpes, human herpes 8, and also the human T-cell leukemic virus is called, and also immunodeficiency of some sort. So it is thought that say a transformative if we remember from the previous lecture, I talked about the germinal center, where B cells, naive B cells mature into plasma secreting B cells, which is really they're into plasma cells, oh my god, which are IgE secreting cells, which is really their natural lives. However, in that germinal center, during that as the naive B cell is undergoing somatic hypermutation, rearrangement in order to mature and become an IgE whatever, because obviously they all have IgM and IgD, then they have to make all the other IgE immunoglobulins. So as during that stage of rearrangement of development, we can say an infection with EBV occurs and it transforms, so it becomes EBV infection becomes transformative and then causes this cell to become a red Steinbeck cell, which then causes causes the secretion of cytokines, and these cytokines then increase growth factors. Then these growth factors obviously feed back to that red Steinbeck cell, causing it to then continuously proliferate and become the dominant cell in that germinal center, and which is really how the cancer transformation occurs. So really it is that transformative, and again this transformation again becomes apoptotic. So it means that it doesn't die. So this is how the cancer becomes generated, and then it presents, and then it must then be managed. It's Hodgkin's lymphoma is managed with ABVD chemotherapy. So the treatment is usually the ABVD chemotherapy. I'm not going to go through the full names, but anyway, that's vinblastine, doxorubicin, bleomycin, and I've forgotten A, but I know it when I say it. Oh gosh, God, I think it's cyclophosphamide. No, but yeah, I think so. Anyway, it's probably not, but anyway, it's managed with this chemotherapy and radiotherapy. Radiotherapy can be used as well. And I think the good thing is that it can be treatable, you know, people can, remission can be induced, and you know, that is the most important thing. And the complications are obviously, you know, when refraction occurs and developing other cancers, and you know, that reduced immunity due to having a cancer, really. So I think these are the most important points to remember, to know about Hodgkin's lymphoma. I'm always trying to shorten these talks to just talk about the most important points. So really the important thing is to at presentation, do excisional biopsy, identify that, you know, so that you can see what cells are there, classify it based on whether it's classical or the nodular lymphocyte predominant, and then do a CT scan to stage, and then based on the staging, obviously it can be stage 1, 2, 3, or 4 based on the NABA, then treat. Those are the most important points to remember. And then I'll just check to see if the lighting is still sufficient. Definitely. And then in terms of the non-Hodgkin's, these are a diverse group of lymphomas that are not Hodgkin's, and are obviously not Hodgkin's because they do not have the red Steinbeck cell. Because if it has a red Steinbeck cell, it is a Hodgkin's. If it doesn't, and it's a lymphoma, it's a non-Hodgkin. So there's a large number, there's an enormous number of these cancers, and really I decided to just only focus on 3 because there's quite a huge number of them, and really, you know, I wouldn't finish them all if I were to try and do them, you know. Again, it's based on the precursor, you know, the precursor, the lymphocyte, as in the mature lymphocyte. Again, precursor B, mature B, then precursor T, N, NK, and again peripheral, which are the mature. And then again, you know, obviously that's 1, 2, 3, 4, and then 5 is Hodgkin's. So we've done this, and now, so this is oh my god, I still